Hello friends, welcome to my YouTube channel. Today we are going to discuss about the cholinergic drugs which act indirectly on cholinergic receptors known as anticholinesterases. This makes good university question, so let's begin. Anticholinesterases are agents which inhibit cholinesterase, protect ACH from hydrolysis, produce cholinergic effects in vivo and potentiate ACH both in vivo and in vitro. Quaternary ammonium anticholinesterases like neostigmine have additional direct action on nicotinic cholinesterase. Mechanism of action: the anticholinesterases react with the enzyme essentially in the same way as ACH. The carbamates and phosphates respectively carbamylate and phosphorylate the esteratic site of the enzyme, whereas the acetylated enzyme reacts with water extremely rapidly and the esteratic site is freed in a fraction of a millisecond. The carbamylated enzyme, reversible inhibitors, reacts slowly, and the phosphorylated enzyme, irreversible inhibitors, reacts extremely slowly or not at all. It is noteworthy that edrophonium and tacrine attach only to the anionic site and do not form covalent bonds with the enzyme, showing a brief action. While organophosphates attach only to the esteratic site, forming strong covalent bonds, thus having longer action of duration. Pharmacological actions: the actions of anticholinesterases are due to amplification of endogenous ACH. As such, they are qualitatively similar to those of directly acting cholineceptor stimulants. However, relative intensity of action on muscarinic, ganglionic, skeletal muscle and CNS sites varies among the different agents. Lipid-soluble agents, physostigmine and organophosphates, have more marked muscarinic and CNS effects. Stimulate ganglia, but action on skeletal muscles is less prominent. Lipid-insoluble agents, neostigmine and other quaternary ammonium compounds, produce more marked effect on the skeletal muscles. They have direct action on muscle endplate NM receptors as well, stimulate ganglia, but muscarinic effects are less prominent. They do not penetrate CNS and have no central effects. Ganglia local hydrolysis of ACH is less important in ganglia. Inactivation occurs partly by diffusion and hydrolysis in plasma. Anticholinesterases stimulate ganglia primarily through muscarinic receptors present there. High doses cause persistent depolarization of the ganglionic nicotinic receptors and blockade of transmission. CVS cardiovascular effects of anticholinesterases are complex. Whereas muscarinic action would produce bradycardia and hypotension, fall in BP is mainly due to bradycardia. Ganglionic stimulation would tend to increase heart rate and BP. Action on medullary centers, stimulation followed by depression, further complicates the picture. So does ganglionic blockade with high doses. Thus, the overall effects are often unpredictable and depend on the agent and its dose. Bradycardia and a small rise in BP are common with moderate doses of many antichs. Skeletal muscles after treatment with anticholinesterases. The ACH released by a single nerve impulse is not immediately destroyed. Rebinds to the same receptor, diffuses to act on neighboring receptors and causes retrograde activation of prejunctional fibers. The resulting repetitive firing produces twitching and fasciculations. Force of contraction in partially curarized and myasthenic muscles is increased, but muscle twitching is not prominent. Higher doses cause persistent depolarization of endplates resulting in blockade of neuromuscular transmission, giving rise to weakness and paralysis. CNS lipophilic anticholinesterases which penetrate into brain produce a generalized alerting response. Cognitive function may be improved in Alzheimer's disease. However, higher doses produce excitement, mental confusion, disorientation, tremors and convulsions followed by coma. Other effects: these result from stimulation of smooth muscles and glands of the gastrointestinal, respiratory, urinary tracts and in the eye as described for ACH, viz. enhanced G.I. motility and secretion, bronchoconstriction and increased airway secretion, voiding of bladder due to detrusor muscle contraction with trigon and sphincter relaxation, meiosis and ciliary muscle contraction leads to lowering of intraocular tension and glaucoma. Let's see about the therapeutic uses anticholinesterases. Its classification has been covered in another video. You can check that video in the Pharma playlist. 1. Paralytic ileus and atony of the urinary bladder. In the treatment of both paralytic ileus and urinary bladder atony, neostigmine generally is preferred among the anticholinesterases agents. Directly acting muscarinic agonists are employed for the same purposes. Neostigmine is used for the relief of abdominal distension and acute colonic pseudo-obstruction from a variety of medical and surgical causes. The usual subcutaneous dose of neostigmine methyl sulfate for postoperative paralytic ileus is 0.5 mg, given as needed. Peristaltic activity commences 10 to 30 minutes after parenteral administration, whereas 2 to 4 H are required after oral administration of neostigmine bromide, 15 to 30 mg. It may be necessary to assist evacuation with a small low enema or gas with a rectal tube. When neostigmine is used for the treatment of atony of the detrusor muscle of the urinary bladder, postoperative dysuria is relieved. The drug is used in a similar dose and manner as in the management of paralytic ileus. Neostigmine should not be used when the intestine or urinary bladder is obstructed, when peritonitis is present, when the viability of the bowel is doubtful, or when bowel dysfunction results from inflammatory bowel disease. 2. Myasthenia gravis diagnosis. The edrophonium test is performed by rapid intravenous injection of 2 mg of edrophonium chloride, followed 45 seconds later by an additional 8 mg if the first dose is without effect. A positive response consists of brief improvement in strength, unaccompanied by lingual fasciculation, which generally occurs in non-myasthenic patients. B. Provocative test. Myasthenics are highly sensitive to D-tubocurarine, 0.5 mg I. Versus causes marked weakness in them but is ineffective in non-myasthenics. This test is hazardous. Treatment of myasthenia gravis: pyridostigmine, neostigmine, and ambenonium are the standard anticholinesterases drugs used in the symptomatic treatment of myasthenia gravis. All can increase the response of myasthenic muscle to repetitive nerve impulses, primarily by the preservation of endogenous ACH. Following ACE inhibition, receptors over a greater cross-sectional area of the endplate presumably are exposed to concentrations of ACH that are sufficient for channel opening and production of a postsynaptic endplate potential. Unpredictable exacerbations and remissions of the myasthenic state may require adjustment of dosage. Pyridostigmine is available in sustained-release tablets containing a total of 180 mg, of which 60 mg are released immediately and 120 mg are released over several hours. This preparation is of value in maintaining patients for 6 to 8 H periods but should be limited to use at bedtime. Muscarinic cardiovascular and GI side effects of anticholinesterases agents generally can be controlled by atropine or other anticholinergic drugs. Other therapeutic measures are essential elements in the management of this disease. Glucocorticoids promote clinical improvement in a high percentage of patients. However, when treatment with steroids is continued over prolonged periods, a high incidence of side effects may result. Other immunosuppressive agents, such as azathioprine and cyclosporin and high-dose cyclophosphamide, have also been beneficial in more refractory cases. Removal of antibodies by plasmapheresis, plasma exchange, is another approach. It may produce dramatic but often short-lived improvement in myasthenic crisis.
Thymectomy is now generally advised for patients with generalized weakness, particularly for those with a thymoma and for younger patients. It is effective in majority of the cases.
Thymectomy produces gradual improvement, and even complete remission has been obtained. Thymus may contain modified muscle cells with NRs on their surface, which may be the source of the antigen for production of anti-NR antibodies in myasthenic patients. 3. Alzheimer's disease. A deficiency of intact cholinergic neurons, particularly those extending from subcortical areas such as the nucleus basalis, has been observed in patients with progressive dementia of the Alzheimer type. Using a rationale similar to that in other CNS degenerative diseases, therapy for enhancing concentrations of cholinergic and other neurotransmitters in the CNS has been investigated. In 1993, the FDA approved tacrine, tetrahydroaminoacridine, for use in mild to moderate Alzheimer's disease, but a high incidence of enhanced alanine aminotransferase and hepatotoxicity limited the utility of this drug. Subsequently, donepezil was approved for clinical use and has emerged as the primary agent for treatment in multiple countries initially. 5 mg doses are administered daily, and if tolerated, doses are increased to 10 mg for mild to moderate conditions. Recent clinical trials in moderate to severe Alzheimer's disease have confirmed benefits for a 23 mg, D sustained-release form. Rivastigmine, a more lipid-soluble, longer-acting carbamylating inhibitor, is approved for use in the US and Europe in both oral and skin patch forms. While having similar side effects to other cholinesterase inhibitors, rivastigmine is reported to have shown a higher incidence of fatalities than other cholinesterase inhibitors used in Alzheimer's dementias. 4. Prophylaxis in cholinesterase inhibitor poisoning. Studies in experimental animals have shown that pre-treatment with pyridostigmine reduces the incapacitation and mortality associated with nerve agent poisoning, particularly for agents such as soman that show rapid aging. 5. Intoxication by anticholinergic drugs. In addition to atropine and other muscarinic agents, many other drugs, such as the phenothiazines, antihistamines, and tricyclic antidepressants, have central and peripheral anticholinergic activity. Physostigmine is potentially useful in reversing the central anticholinergic syndrome produced by overdosage or an unusual reaction to these drugs. 6. Cobra bite. Cobra venom has a curare-like neurotoxin. Though specific antivenom serum is the primary treatment, neostigmine plus atropine prevent respiratory paralysis.
Anticholinesterase poisoning. Anticholinesterases are easily available and extensively used as agricultural and household insecticides. Accidental as well as suicidal and homicidal poisoning is common.
Local muscarinic manifestations at the site of exposure, skin, eye, G, I, T, occur immediately and are followed by complex systemic effects due to muscarinic, nicotinic and central actions. They are irritation of eye, lacrimation, salivation, sweating, copious tracheobronchial secretions, meiosis, blurring of vision, bronchospasm, breathlessness, colic, involuntary defecation and urination.
Fall in BP, bradycardia or tachycardia, cardiac arrhythmias, vascular collapse. Muscular fasciculations, weakness, respiratory paralysis, central as well as peripheral. Irritability, disorientation, unsteadiness, tremor, ataxia, convulsions, coma and death. Death is generally due to respiratory failure. Treatment.
Atropine. It is highly effective in counteracting the muscarinic symptoms, but higher doses are required to antagonize the central effects. It does not reverse peripheral muscular paralysis, which is a nicotinic action. All cases of anti-CHE, carbamate or organophosphate, Poisoning must be promptly given atropine 2 mg I versus repeated every 10 minutes till dryness of mouth or other signs of atropinization appear. Up to 200 mg has been administered in a day. Continued treatment with maintenance doses may be required for 1 to 2 weeks. B. Cholinesterase reactivators. Oximes are used to restore neuromuscular transmission only in case of organophosphate anti-CHE poisoning. The phosphorylated CHE reacts very slowly or not at all with water. However, if more reactive O groups in the form of oximes, pralidoxime causes more marked reactivation of skeletal muscle CHE than at autonomic sites and not at all in the CNS, because it does not penetrate into brain. It is injected I versus slowly in a dose of 1 to 2 grams. Children 20 to 40 mg per kilogram. Uses of each individual drug is given in this table. Do take screenshot of this. Thank you for watching. Like, share and subscribe. Follow for more. Goodbye.